My disclosures. So I'll start with the most famous study. This is for the German audience. The study made it even into the Taz. It says implants out of control. For the international audience, it made it into the New York Times. Study is ended as a stent fails to stop stroke, and you all know what I'm talking about. It's the Sampras study. Just briefly, Sampras was stenting versus aggressive medical therapy for intracranial artery stenosis. It included patients with a symptomatic intracranial stenosis, any locations or MCA, ICA, basilar artery of at least 70%. All patients had a recent stroke or TIA within the last 30 days. And it was stopped early after enrollment of 451 patients because the stent had a much worse outcome within the first 30 days than expected. There was a rate of another stroke or death of 14.7%, which was significantly higher than the rate in the best medical treatment arm, which was 5.8%. Best medical treatment included dual antiplatelet, so usually aspirin and clopidogrel, reduction of risk factors, and so-called lifestyle modification program for a healthier lifestyle. While quite a huge number of recurrent strokes and deaths in the first months after the intervention, but this overall benefit of the aggressive medical treatment actually persisted over the time. You can see that after 1 year, there were 20% recurrent strokes and deaths in the stenting arm, which was still significantly higher than in the aggressive medical treatment arm, which was 12%. And you can also see that both curves actually come closer, but they haven't even crossed after 4 years. While Sampras was not the only disaster for intracranial stenting, we also saw VISIT trial. VISIT evaluated the Pharos Vitesse stent, which was a balloon-mounted stent. So basically, it was a cardiac stent. And it was stopped after Sampras came out. And again, bad numbers for intracranial stenting, 15% 1-year rate of recurrent stroke or TIA, which was in the medical group, which was significantly lower than 36% in the stenting group. Well, I had a patient last week. Actually, it was a call from another hospital. They said they have a, I think, 62 years old male patient with a variety of risk factors, arterial hypertension, former smoker, and adipositas. And they said, well, this patient is already under aspirin, and now he has a transient aphasia, he has an MCA stenosis in the CTA, and he has infarction. So we would like to send him to you for stenting. And we said, no, according to Sampras, you have to dual antiplatelet treatment and care of risk factors, and then he will most likely not experience another stroke. So they did this, and on the next day they called again, or 2 days later they called again and said, well, now he is on dual antiplatelet, and now he has another episode with aphasia for about 30 minutes. And again, we refused treatment because we thought they just started this treatment. Next day, they called again and said, now he's on the way to your hospital because he again experienced an episode with aphasia. He was asymptomatic when he arrived, but in the evening he stood up and his blood pressure dropped a little bit. And again, he was symptomatic for 20 minutes. So I think not such an easy decision. And if we want to make a decision for our patients, and we have to do this for every individual patient, I think we have to weigh the risk under aggressive medical management against the risk during and after the stenting procedure. And in order to do so, we have to know what are the influences of the natural risk for intracranial stenosis and what are the influences for the risk of intervention. Well, the conservative risk is quite well known, and we have seen the numbers before. We heard about the VASIT trial. This is warfarin against aspirin trial. It has nothing to do with stenting. But we know that no matter if the patient took aspirin or warfarin, they had a 1-year risk for a recurrent stroke of 18%. In the Sampras trial, the best medical treatment arm had a stroke risk of 12% within the first year. I already showed you the number. And in VISIT, it was even 15%. So negatively spoken, 1 to 2 patients out of 10 patients will have another stroke within the first year after the first event. While the influences of the natural risk or the risk under conservative treatment, this is a subgroup analysis from the Sampras study, and if you look at the best medical treatment arm, we can see that the easy influencing factors, easy factors like age, gender, localization of the stenosis, or if the patient was on antithrombotic medication or not, or when was the qualifying event, did not have any influence on the natural risk. On the other hand, this is again not symptomatic, but patients who had a stroke, not in TIA as the qualifying event, had a higher risk, higher tendency for another stroke. And this risk was especially high in patients who were under antithrombotic medication, who had a stroke, not in TIA. In the territory of the qualifying stenosis, when compared to patients who had a TIA or were not under antithrombotic medication, and who had old infarctions on MRI. Sorry. The degree of stenosis is important for the risk for another stroke under medical treatment. This is what we have from the VASIT trial, again, warfarin against aspirin, and they looked at patients with a high-grade stenosis, so stenosis of at least 70%, and you can see that they are under a significantly higher risk than patients with a stenosis of 70% or less. This is not a randomized trial, but I think this is quite interesting. It's a registry where they looked at different factors that influenced the risk for another stroke in patients with an MCA and basilar artery occlusion, and they found that a hemodynamic infarct pattern on MRI, and the so-called border zone infarctions, was an independent predictor for another stroke within 1 week. So if you have a patient with this pattern, he will be on a high risk for another stroke. This is from the Veritas study. This is a study on vertebrobasilar artery occlusions. It's a registry study, and they also showed that the stenosis grade is very important. They did a quantitative flow measurement with an MR angiogram, and they divided patient into low flow, so patients who had a low flow behind the stenosis, to patients who had a normal flow distal to the stenosis, and patients with a normal flow were under a lower risk for another stroke. So this was again significant. Also from the VASIT trial, we probably all know patients with an MCA occlusion or even ICA occlusion or basilar artery occlusion without any symptoms, and those patients usually have excellent collaterals, and this is what VASIT also showed. Patients with poor or moderate or no collaterals are under significantly higher risk than patients with good collaterals. Well, just a brief summary, what influences the natural risk is the grade of the stenosis. So patients with an at least 70% stenosis are under the highest risk. Patients who have a hemodynamic infarct pattern on MRI or CT scan have a especially high risk. Patients with poor collaterals, and well, there's some evidence that stroke patients have a higher risk than TIA patients, and in Sampras, patients with an old infarct and strokes while on antiplatelet medication also were on a higher risk. Well, on the other hand, what influences the risk of intervention? This is the Wingspan registry. Wingspan was introduced in 2007 into the market. This registry included 45 patients with a stenosis of more than 50%. All were symptomatic under medication, and the intervention was performed at least 30 days after the clinical event. And well, this is the results. A new stroke or death occurred in 4.5% within 1 month and in 7% within 6 months. Just as a reminder, this is the data from Sampras. So you can see that the numbers are threefold higher than in the Wingspan registry. Again, the subgroup analysis from Sampras. Again, we look at the easy factors like age and gender, and if the patients were on antithrombotic medication at the time of the qualifying event, and all this did not influence the risk for the intervention. There was a tendency for higher risk in patients with vertebrobasilar artery stenosis, and if the intervention was performed early, so within the first 7 days after the clinical event. Well, if we look at the the data from the Sampras a little bit closer, 33 patients in the stenting group had another stroke. 25 of them within 1 day and 8 within 2 to 6 days. So very early recurrent strokes. And well, actually 10 of those 33 infarctions were hemorrhage. 5 were reperfusion hemorrhages, and 4 of them were clearly via perforation. So I wouldn't really call this another stroke. I would call this a periprocedural complication, and we have already talked about this today. This is, in my opinion, unacceptable high. Well, who treated in Sampras? There was quite a limited experience with the Wingspan system. More than 3 or at least 3 Wingspan interventions were required to participate in Sampras. Average was 10 Wingspan stent cases. And if we look at the hemorrhage rate, there was a significant difference between high volume centers, so experienced interventionists who did at least 12 cases had a hemorrhage rate of 2%, while centers with less than 12 patients had a hemorrhage rate of 8%, so 4-fold higher. Well, after Sampras was stopped and after Sampras was published, the FDA narrowed the criteria for the use of the Wingspan system and required another registry, which was the WEAVE registry. We've included patients with symptomatic intracranial stenosis of at least 70%. Patients were required to have 2 strokes in the vascular territory of the stenotic lesion and at least 1 stroke while on medical therapy. And the stenting had to be performed at least 8 days after the clinical or the last clinical event. And this is briefly the results of the WEAVE trial. Total percentage of patients with another stroke or death within 3 days were 2.6%. So this was lower than expected. And well, why was this? One of the reason was that we've only included very experienced interventionalists. So the mean case volume before they entered the study was 37 stent procedures, which is quite high, I think. And another important point is that antiplatelet resistance was tested before the stenting was performed. Woven is the extended version of WEAVE, so it's the same patient group, but it's the long-term results. And if we look at the 12-month result, we can see that only 8.5% of those very selective patients had another stroke or a death. So this is much lower than the aggressive medical treatment arm in Sampras. Again, this was 12.2%, and of course, much lower than the stenting group in the Sampras study with 20%. Well, I come back to my patient. We performed an angiogram. We saw that he really had severely impaired flow distal to the stenosis. And in the lateral view, I would say he had none to poor collaterals. And so we were thinking natural risk is quite high because he has a high-grade stenosis, he has hemodynamic infarct pattern, he has poor collaterals. On the other hand, he had no old infarctions. Risk of intervention, well, we were only on day 4 after the initial event. He was, on the other hand, a responder. It was not in vertebrobasilar artery stenosis, and well, we are at least quite experienced. And then if we look at the stenosis, of course, easy to reach. I would say the only thing that I didn't like was this dominant perforator that arises in the middle of the stenosis. But altogether, we decided that the natural risk would be higher than the risk of stenting. So we used Neurospeed and Credo. I personally like to leave some residual stenosis to be careful, and hope to avoid a reperfusion syndrome with this. So this is the final result. The flow is good now, so we don't have any impaired flow. And he's fine. He was discharged on Friday with 0 symptoms. So I think I did the right decision in this case, but I think it's not always easy, and this is the way that we do when we include all the knowledge we have from the different studies. We have to look at the stenosis grade, we have to look at the collateral status, we have to look at the infarct pattern. We have to know our own complication rate. So Sampras complication rate, that doesn't matter. You really have to know your own complication rate. And then we have to look at the lesion location. Is it reachable? And I think the morphology is also important. We do always do responder testing, and I think it's important to have a device that you really know, that you have experience with, and I personally like that. I don't like exchange maneuvers. And just by the way, 5 of those 6 factors were not included in the Sampras and in the VISIT trial. So I think we really need new data. Weave and Woven showed us that we can do better. And on the other hand, patients on best medical treatment still have a quite high risk for recurrent stenosis. And I would really like to have another randomized trial with a good patient selection and experienced interventionalist. Thank you very much.
Thank you, Dr. Dorn. Is there any question from the audience? Yes, just a comment for me. I think you are in a perfect way, because we have to to know that there is not data coming from randomized clinical trial to justify the treatment of all the patients with symptomatic intracranial stenosis, and we have to highly select the patients. And the kind of algorithm you showed, I think it's very, very correct, no? To show to demonstrate the patient is not having a good collaterals and is not responding to the mechanical therapy. I think that's the good way to select the patients, and maybe in this way we can demonstrate finally, in a randomized clinical trial, the benefit of the angioplasty and stent. So this is, I think that we have to consider, and also maybe we have to talk with the patient and with the family in elective patients, and to speak and talk about the risk of conservative treatment and the vascular treatment as well.
Yeah. Yeah, I think we are still talking about a study that has been published more than 10 years ago, and this is what we actually all base our decisions, at least partially on Sampras. So I think there's really a need for another randomized trial. Yeah.
And also a question: do you always test the response of antiplatelet treatment before deploy the stent in 100% of patients?
We always, in elective cases, yes, we always do. Yeah.
Okay.
Yeah.
So I got one question. So you told us that when there's a hemodynamic pattern, this is a predictor for bad prognosis, so that this is a hemodynamic problem and not a thromboembolic problem. And to be honest, before the Sampras trial, we treated so many intracranial stenosis, and we had our problems and we had our complications. And a lot of things found in those trials were not a complete surprise. And for me, what I've learned from those trials was, if you think this is a thromboembolic problem, you can treat this by medication quite well. And the patients which come back are the hemodynamic impaired patients. And what about, so I personally hate perfusion imaging in stroke treatment for decision making in normal thrombectomy. But what about perfusion imaging or some more detailed criteria to assess the hemodynamic component? What is in your practice?
Yeah, we don't do a lot of perfusion imaging. Actually, we look at the infarct pattern, and but still, I mean, the question is if we have a patient with where we can see poor collaterals because we, for instance, do CT perfusion or 4D CTA or something like this to check the collateral status, but then we would still have to wait for the second event, right? I mean, this is what Sampras taught us and what's in the guidelines now. And as you said, sometimes we have a patient and we know he's coming back because he has a hemodynamic stenosis. So it would be nice to check this and then go straight for stenting, maybe.
It was one of the most frustrating consequences of Sampras that we treat the patient after the stroke, not before.
Yeah.
It's true. So, further questions?
Would you find useful the FFR measurement, for example, as yesterday was it presented, I think, in one of the presentations? Whether the stenosis is hemodynamically significant.
Yeah.
And use like FFR catheter to somehow assess whether it is really serious or not.
I have zero experience with these catheters, but well, I think it's probably not so easy to. I mean, then you have an intervention to do, right? I mean, would you do this in a patient, and then if you see it's not hemodynamic relevant, would you take him from the table, or would you go straight for stenting? I don't know. Probably it's a good idea, but I personally wouldn't like to do it. Either I go for stenting or not. Yeah.
What I learned from these 2 days is that we have to forget about Sampras. I hate it. It's an old trial done with old materials, with all the. We don't talk about Sampras, and we can't base our practice using the Sampras results. Yeah. I think we should forget it, and should forget it also in doing guidelines, because it's just not good for patients. It's terrible. Most of patients treated in the Sampras, probably now we treat them in acute phases, and we stent them, all of them, and they go well. We have to forget it.
But it's in the guidelines, no? So it's the evidence, no? So the so-called best evidence we have. No?
But our community of neurointervention is extremely dynamic, is full of brilliant people, and we should go ahead. It's impossible to base our practice on a trial published in 2011, more than 10 years ago. Cases done 4 or 5 years before, with different materials, different medication, in this time lapse, the world changed. It's impossible to base our practice and our guidelines in this trial.
Yeah, I think what Semperis taught us is that patient selection is crucial, and if you plan a study, you really have to define your inclusion criteria, because it wasn't ideal before Semperis either. As Paul said, we had many, many complications with intracranial stenting, on not good outcomes at least. And now I feel that complication rate is really low. It's just a problem with restenosis, but this is another topic. But if you select your patient well, you will not see so many recurrences.